Aloha and welcome, everyone. Thanks so much for sticking with us at the State of Reform 2022. Thanks for being a part of the early panel discussions this morning and for tuning in to the lunchtime keynote. We're really excited to welcome you back, and we'll be discussing how the social determinants of health impact our Ohana here in Hawaii. I'm really pleased to welcome you all. I'm Kealoha Fox with Aloha Care, and I have the pleasure and the honor to moderate today's panel. We know that SDOH are primary drivers to health and healthcare, overall wellness in Hawaii in all places. So today we're really looking forward to jumping in. We're going to talk about new research and publications. We're going to talk about programs and community services. We're also going to talk about issues and gaps that still persist that we want to work together to overcome. As our organizations frequently partner and collaborate, we hope to demonstrate these lived values of what it means to be an ohana within the healthcare system and try to be great agents of change as we look at the outlook for 2022 ahead. I'm going to start by introducing each one of our panelists, and then they'll share a brief presentation. After that, we welcome you to join with us into the chat. If you have any questions, there's a Q&A feature in the right panel on your screen. Go ahead and just drop us a question that you might have for any specific panelist or for all the panelists, and I'll be able to help to moderate that. We did leave time for discussion. And then in the chat feature, please engage with us. Though we're virtual, it doesn't mean that we have to be static. So we welcome any of your thoughts and ideas and your wonders and your affirmations as you sit and you listen with us too, since we know all of you are experts in your own right, and we're just really happy to work with all of you and have you a part of our network. First, I'm pleased to introduce the Chief Executive Officer of Aloha Care, Francoise Cully-Trotman, who was appointed CEO in April 2020. And she's brought a wealth of experience to our organization in finance, in legal and compliance and regulatory services. She was previously our Chief Compliance Officer. Born and raised in Guyana, South America, Francoise actually visited Hawaii for the first time for her children's karate tournaments. And she really fell in love with the way in which she and her family felt the spirit of aloha. And that really drew them to want to be a part of our community here. And so we're really happy and fortunate to have someone like Francoise as our leader right now, helping us grapple with these issues. And Aloha Care started with great leadership. And that's where I get to introduce one of my good friends, somebody I look up to so much, and that's Beth Geestein, the retired director of the Hawaii Budget and Policy Center. Beth needs absolutely no introductions for us here at the State of Reform. She's always a part of this network, and she's usually one of the first people that us here, we text and call and email Beth. But I'm going to share that I was so happy to recently celebrate Beth's retirement. Beth, you have been a lifelong public servant, and you have given so much to public health here in Hawaii. As a founding board member of Aloha Care, you mean a lot to our organization and to those of us in public health policy, advocacy, community health centers, research and writing and legislative reform. You mean a lot to us across the entire sector. So just congratulations and mahalo to you, Beth. And we have more congratulations and mahalo, and that's with me having the privilege to introduce Helen K. Kalia as the Chief Executive Officer as Molokai Community Health Center. Helen is celebrating her 10th anniversary with the CHC this year and her 5th year as CEO. As you know, Helen, she's born and raised and lives and works on the island of Molokai, and she spent her career advocating and serving her island and her community home. And she started in social services, she continues in healthcare, and she has a really unique lens of how do you blend and integrate all of that together through an FQHC. Just please help me virtually welcome. I'm Pa'i Lima. These are 3 incredible, diverse women, executives and leaders who work day in and day out to support the health of Hawaii and definitely help us to address and integrate social care. I'm going to go ahead and start off with Francoise first. Now, bringing up slides here for you folks to follow along. And this will just help us guide the visuals for the conversation. Francoise, I'll go ahead and turn it over to you now.
Thank you, Kealoha. Welcome and aloha, everyone. Thank you all for joining us today, and thank you to the State of Reform team for the invitation to participate. I'm very happy to share space with Kealoha and Beth and Helen, and in particular to share what Aloha Care and other like-minded organizations are doing to address the social determinants of health. I'll be very conscious of time, so I'll just jump right into it. So Aloha Care is a safety net plan serving unique and just culturally rich communities across the islands of Hawaii. As CEO, I have come to learn that this is a place that truly lives through the power and the potential of the community. We serve very diverse groups of Medicaid and Medicare dual eligible members, as you can see on this slide. And from our earliest beginnings, our priority has been improving the overall health and the quality of life for our members and their communities. We know that healthcare experts attribute only 10 to 20% of health outcomes to medical care, and the rest is really largely attributed to social determinants of health, including social and physical environment. So health plans like us, we fund the cost of SDOH services as an administrative or quality improvement expense. And so we'll just move into talking about how Aloha Care has answered that call to action to address the social determinants of health. In earlier this year, we launched a multi-year SDOH transformation plan and a strategy spanning the years 21 to 26. The really strong basis for that work started when we conducted an SDOH opportunity assessment with ACAP and a company called the Spring Street Exchange. Our process included analyzing our own member data in order to better understand who we're serving and to just know more about their needs. And so, three major trends that we saw were primary medical conditions that indicate a high degree of preventable and manageable chronic conditions. So, diabetes, CKD, congestive heart failure. We saw primary BH conditions, depression and anxiety, and use of tobacco and alcohol. And last but not least, of course, the SDOH factors were prevalent: financial instability, food insecurity, social isolation, and housing and all of the associated costs, like utilities and skilled facilities, etc. So our plan, from left to right, really focuses on the core domains that make the biggest impact on our members over the next several years. And you'll see that the pillars incorporate both the structural determinants of health, such as neighborhood, built environment, etc., all the way to housing instability and lack of family-oriented shelters. We focused a lot on the opportunity. So as we move to slide 4, wanted to talk with you a lot about community-based organizations and how critical they are to the work that we're doing. A lot of the CBOs that provide food and shelter and other unmet social needs are not recognized enough, but they are critical to reversing or reducing health inequities. Some of the important partnerships that I'll highlight just over these 4 quadrants, deliver mobile health care, they address food access, they support virtual healthcare like telehealth, and housing support, which has been especially impactful during the pandemic. I'll just pause here to say that we know we've had these problems as a nation and as communities, but the pandemic made it really difficult to ignore the people who are most impacted by this. We recognize that access to healthy food is a first step to overall health. And so, briefly, I'll mention that Aloha Care has a long-standing commitment to address food insecurity in our communities. We share that passion with many of the local health plans, which I'd like to acknowledge today. We keep our commitment via grants to the food pantries, the food baskets, state and federal initiatives that the state's deploying. We try to support those food prescription programs, etc. And we also host our own Farm Fresh Fridays on Oahu. As far as telehealth grants and other provider partnership that helps us to support access to care, we really have carved out a space for high risk patients and bringing care into the community with them. And so I just want to spend some time talking about two partners and hoping that it gives food for thought for others that are thinking of supporting these types of efforts. Under the guidance of the University of Hawaii JAPSOM, Maternal and Fetal Health Division, a program called MI Home has been launched by Dr. Menjin Lee and Leah Minton, a certified nurse midwife. And they take care into the community for pregnant and postpartum moms that are hesitant or simply don't find it feasible to seek care in a traditional setting. The interesting thing about this program is during those consults, if it's determined that additional care is needed, they offer telemedicine consults and other support from maternal fetal medicine providers. It's proved very helpful for not just our members, but others in the communities. And I encourage others to find a way to support this initiative if you can. We also partner with Healthy Moms, Healthy Babies. They've been here for 25 years, and I think it's important to just acknowledge that they go way beyond clinical care. They offer pregnant patients support, but also vital supplies, basic needed supplies that are not easy to access. And then you'll hear more from Beth Keasting on housing, but I also want to say we are proud to support the work of Hawaii Appleseed and the Hawaii Budget and Policy Center, highlighting the need for effective housing and help policies and strategic investments to address affordable housing. So overall, CBOs really lend a very strong voice to help shape policy and ultimately to fund SDOH initiatives. As we wrap up, I'd just like to quickly say we've launched a platform called Unitis, which is a closed loop referral platform. And this really is as much a tool for us as it is a tool for the CBOs that have been providing these services for years. We have about 133 active organizations at this point, an additional 400 or more leads just in 6 months. And what this does is really just helps both the CBOs and ourselves to confirm that members are accessing the right services, that we are targeting areas where there's a true need and making those connections. And as I, wrap up, it's hard not to talk about how we use data now and in the future. In our short experience, we've already seen that the data allows us to really focus in on those areas, as I shared before, that there's a true need. And we've been able to confirm that the things we know, like housing and shelter and employment, and individual and family support, really make a critical difference. We're really hoping to use that data to help support our lawmakers and the rest of the communities who also want to help support policymaking in this area. And so excited for the prospect and what we can do with the Unitis initiative. It would be very remiss of me not to thank all of our CBOs that have worked very hard and given us their time and spirit to make that effort successful, as well as Kaiser Permanente, who is a partner in that initiative. Very excited for our second year of implementation, and we welcome others to join us. In closing, if you're wondering, how are we living the things that we are sharing and what can you do in your own organizations, we encourage you to try to think of ways of using SDOH data. Try to assess the gaps that address your members or your patients' social risk factors. Training is critical. Using data and technology in innovative ways to close gaps and to close the referral loops or socially unmet needs. And then really having a commitment to investing in the resourcing to support social health integration. As we've talked about, it's really impossible to do this without the rest of the community. And so, as I said, in the interest of time, I'll thank you in advance for listening and just hand it back to Kealoha.
Thanks so much, Francoise. Thanks for helping us set the tone and show what one safety net health plan like Aloha Care is able to accomplish and work on as our lessons learned in the pandemic. Beth is going to pick up right there from one of those quadrants that Francoise was talking about, and the really important nexus between good health and safe housing. Beth, please share with us this research that you've conducted in the publications that folks definitely want to learn about. Beth, just 1 second. Make sure if you can unmute yourself at the top. Thanks.
Yeah, okay. So thank you.
My pandemic saying, unmute.
Unmute. Yes, that's right. It's the key phrase. So it is a pleasure to be here. And I am also very grateful to Aloha Care and to Hawaii Pacific Health for sponsoring the research and the publication that we just completed on the nexus between good health and decent housing. We all know about social determinants of health, so this is specific to the effects of housing on good health. And so there are several different aspects. Neglected neighborhoods is very important. Neighborhoods that don't have sidewalks and trees and parks, dilapidated buildings. It creates a lot of stress and fear of safety. Harmful housing is a big issue as well. Low-income housing is much more likely to be located in areas that are polluted or have other kinds of environmental issues, being close to freeways. Poor housing also is more likely to have pests infesting them, broken or rundown appliances can cause injuries. But I think one of the major issues about housing is just the economic stress. Housing is the most expensive part of most households' budgets, and making sure that you can keep a roof over your head causes a tremendous amount of stress, and also may end up in people not being able to afford other things that they need for their daily living requirements, including medicine and good food. So this just shows some of the chronic diseases that are related to poor housing. So asthma is one of them, diabetes, high blood pressure, stroke, coronary heart disease, and of course, depression and anxiety. And this shows low-income households as a proxy for people who are affected by housing. And it also shows the tremendous expense for treating people with these conditions. So we know that where we are not taking care of housing needs, we're paying for it by having increased healthcare costs. Now, of course, people who are experiencing homelessness are much worse off than even other people who are experiencing housing stresses. Part of that is related to the kinds of living conditions that they face, the chaos, the violence, the stress of having to deal with most of the public who treat homeless people with contempt and a lack of sympathy. But also people who are experiencing homelessness are much less likely to get regular preventive healthcare, regular healthcare of any kind. They just are not organized, or our healthcare system is not organized to take care of people who are experiencing homelessness. And so these folks are much more likely to access care through the emergency room, be admitted because of the advanced state of their disease. And there are a couple of data sets that I cited in my report that talk about an average per facility of 50 to 80 patients per month, and an average of more than $8.5 million in charges every month. So this is a really tremendously expensive problem for us. But the good news is that there's a lot of evidence that shows that permanent to supportive housing and other kinds of interventions can make a tremendous difference and save a whole lot of money. And here are just 3 examples. The Queen's Care Coalition has shown with a relatively small number of participants that they were able to save $42,000 per year per participant in healthcare costs. The Hawaii Pathways Project served 134 participants, and they saved more than $55,000 in healthcare costs, and they netted out almost $32,000 in savings per year because, of course, they invested in interventions. And then CHS study estimates that for 1,800 participants in Hawaii, we would net about $18,500 per person who is in these. And so these would be people who are experiencing homelessness on a chronic basis. So the good thing is that these are the kinds of interventions that our MedQuest program and its contracted health plans and community-based organizations are all working on. Housing first and permanent to supportive housing for people who are experiencing chronic homelessness. But then there are a lot of other things that I would just note that we need to continue to support in order to address homelessness in Hawaii, including prevention and rapid rehousing, keeping people from becoming homeless in the first place, increasing the amount of housing vouchers that are available, and also making sure that there are landlords who will take them, because that is one of the barriers. Even though we don't have enough housing vouchers, even then people who have access to them can't use them. And then we still need a network of emergency shelters and services. But here's the bottom line. We can't solve the problems, not for homelessness, not for the poor health related to housing, unless we deal with the problem of not having enough affordable housing. And so I know that you all are well aware of this here in Hawaii. We have the most expensive housing market in the country. If you buy a house, it costs, well, this was at the beginning of 2021. It's way more than this now. But rents also are much higher here than the national average. And what makes it worse is that working people in Hawaii can't afford the high cost of housing, because people here tend to have low wage jobs. And so this first graph shows that in 2018, the rent wage for Hawaii was $20 more per hour than the actual average wage. I mean, people can't afford to rent. The second graph shows that more than half of the population in Hawaii are cost burdened by their housing. So this is just another illustration. It shows that even people who are making 100% of area median income, that is people who are supposed to be doing okay, even more than that, for that population, more than 10% of the families can't find housing that they can afford. And of course, that becomes much worse. If you're at 30% of area median income, more than 60%, you're not going to be able to get housing. So just wanted to show that a couple of years ago, a state agency commissioned a study that looked at housing needs over the next 5 years for Hawaii. And this study showed that 54,000 housing units are going to be needed between, at that time, it was 2020 and 2025. And as you can see, the vast majority, 2/3 of the housing that's needed is for people who are not able to pay market rents. Or pay for a house on the market. And that's a real problem, because we're not producing the housing that people need here in Hawaii. So I just want to tell you, though, that available decent housing is a policy choice. It is not foreordained that we can never have housing policy that meets our needs here. So it is true that we can reduce the cost of building, we can expand rent subsidies, we can maximize the potential of low-income housing tax credits. We can make affordability long-term so that the publicly supported housing that we build is always available to people who need it. These are policy choices that are being developed by my former home agency, Hawaii Appleseed. I've got to say, I'm very pleased because they are being embraced and looked at very closely by our counties, by our states, and they're in practice in many other locales. So it is something that we can work on. So in closing, I just want to say, I hope that you will all embrace housing as a health crisis and inform yourself about the problem and support initiatives and advocate for more housing to address our health needs here in Hawaii. And this provides a link to the publications that were just loaded onto our website. And I again want to thank Aloha Care and Hawaii Pacific Health for supporting it. So back to you, Kealoha.
Beth, thank you so much. You provided so much important food for thought. I want to dig into some of that data really quick. As we get set to have Helen do a brief presentation, one of the things that really jumped out for me while you were speaking, Beth, is that when we focus on SDOH, we don't just have an opportunity to make good investments each fiscal year. We have a great opportunity to have cost benefit and a return on these investments for many generations to come. So thank you so much, Beth. Much more to come. Helen, I want us to be able to learn from you now and your deep work serving the community of Molokai and how SDOH are impacting Ohana of Molokai Nui Ahina.
Hi, good afternoon, everyone. Thank you so much, Kealoha, for that wonderful introduction. And again, the honor and the pleasure is on this side. So I do appreciate the opportunity to be here with all of you today. And again, a much appreciation to the State of Reform for the invitation to share in this discussion. I get to share the pleasure of kind of taking this conversation down into the boots on the ground perspective with all of you. So with that, let me go ahead and kick us off with a brief overview on who we are, just in case you're not familiar with FQHCs or with community health centers. Molokai Community Health Center is the only federally qualified community health center on Molokai. There's 4 of us in Maui County, so we're also the second largest there. At 50 employees, we're one of the larger employers on the island, spending approximately $6 million per year, making us a substantial economic engine for the community. With 71% of our staff being from Molokai, and that's including myself, we are proud to be creating jobs within our community for our community. We are a one-stop shop location, patient-centered medical home, if you will. So we're centrally located right in town. And you can see here the range of services that we provide. I won't read those to you. You can also see some data points here about our patient demographics to get an idea of who we serve. I'll highlight, in addition, that nearly half of our total population is pediatrics. So we are a family medical home through and through. And what the recent census is highlighting for us and decisions we make moving forward is that our island home populace is slowly shrinking. Some other services I'll go ahead and just highlight that we provided the community is some rental space. So speaking of housing in different spaces to congregate and gather and produce services. We do offer office space, space for events, and our site actually hosts the only centrally located certified kitchen for rent in the community. If you want to go ahead and skip to the next, Kealoha. I won't spend too much time here and I won't read this for you all, but I did just want to take a moment to speak to the vision of the Community Health Center movement, which is to speak to CHCs and their overall mission nationwide. Given today's topic, I thought it was also fitting to share this quote from you from CHC founder, Dr. Jack Geiger, of the work that Community Health Centers' history and core values are rooted in. CHCs were born out of the civil rights movement in the 60s. So this quote from Dr. Geiger highlights the notion of actively using healthcare as a means to not just improve one's health outcomes, but to ultimately move people out of poverty. And this being the ultimate determinant to creating upstream intergenerational change for both families and community. So again, I highlight this as this work is really in our genealogy as community health centers. Next slide. Going into core values, remember, I'm coming from boots on the ground perspective. So as Francoise pointed out earlier, social determinants of health is a complex system. It's multi-layered, and it is varied amongst people, place, and politics. So I'm sharing this just as a way to quickly root us in this basic principle in play here, which is health equity, human rights, and distributions of power, and our role in helping to ensure a better future for tomorrow. Moving next into the actual social context and social determinants defined. As you can see through this graph, social and economic factors, education, employment, income, family support, to physical environment, air, housing, water. Water is a big topic right now, big problem still these days. And then the healthy behaviors section make up 80% of a person's general wellness. I prefer to look at these as social drivers. What we hear very often from patients on the ground are statements around, I don't like change, I don't know how to use that or do that. Some very fatalistic attitudes when it comes to chronic disease and chronic disease management. So for us to kind of penetrate changing a mindset here, that 80% that's reflected in this graph is really reflective of choices that people make on behalf of themselves and their families, if they're parents, day in and day out. So if we want to see improvement in the 20% of the pie as providers, then we need to respond to the 80% of the pie that's causing the dis-ease and eventually disease with our patients. So when we look at these factors as drivers, one social context does not have to be a determinant. It can be a driver for change, for positive change. Next. Thank you. So quick little service report to share with you some community-based examples straight from our clinic. Over the last 15 years, MCHC has been in the community. Its primary focus when it came to social service programs was with a small and specialized early education program. So that was really the closest we were hitting to SDOH integrated services. My background, I come from a social service background, as Kealoha mentioned. So preventive health and social service programs are my passion. And as pointed out by both Francoise and Beth, nothing has really shown us more than the COVID pandemic, just some of the basic needs that really needed to be addressed with patients. Next. So to give you an idea of the ways that we have expanded the services that we provide for our community to address those social determinants, starting with food security. When COVID-19 hit our island, it literally started at the grocery store and the entire town shut down for sanitation. I'm happy to speak to some of the details of this impact, but it did end up and lead to, if some of you followed during that time, the early lockdown, the news, Mokulele Airlines actually stepped up to the plate and offered to have groceries flown into Molokai for families. Everyone pretty much experiences this at least once. And I can tell you that that is a pretty hard coordinated effort to work with friends, coworkers, family on outer islands to get your food flown in. The average wait time to pick up your groceries doing that was 1 hour. So the pandemic, as it's, I think, infamously done in many sectors of our personal business lives, really intensified what we already knew was broken or breaking. So we really got together as a team and tried to find the fastest way to get a response back to our communities and create greater access to affordable and fresh food for people now. We also wanted to use the time, leverage the time and energy of doing this work to create a long-term solution that would be sustainable over time. So we worked fast and furious. We've partnered with Aloha Care to launch emergency food distribution via the Farm Fresh Food program that Francoise mentioned earlier. As you can see here, that we quickly evolved. We simultaneously evolved the program and leveraged partnerships with both private and public funders to be able to make this possible. And what we have now is Molokai's largest on-site food pantry, not a food drive that is open 5 days a week. We offer not just food commodities, but fresh frozen foods, local produce and eggs. And we're also a proud partner and sole distributor with Ma'i Movement for Molokai, providing free feminine hygiene kits in response to period poverty. Okay. The second area that we addressed was environmental risk factor for our community, our patients in particular. And this is that they experienced a greater burden through the pandemic with public transportation. So we have historically partnered with the Maui Economic Opportunity Transit Service Program to provide direct drop-off of our patients to their appointments. And after COVID hit, it really became clear to us that we needed to provide direct non-emergency medical transportation for our patients and mobile medical services. Again, public and private funding partnerships made these large-scale initiatives possible. And there's a couple different ways, I think, factors that went into the vision behind launching the program. So I will highlight that our mobile primary care and telehealth clinic is not just an effort to meet patients where they're at and where they feel safe, which is in their home and in their neighborhoods, but it also helped to eliminate gaps that we were seeing with telehealth really not being an option. So although we pivoted to telehealth services during the pandemic, it wasn't a solution for everybody, specifically those who lived in rural areas where they didn't have broadband, and of course, those who can't afford internet as well as different mobile devices. Next. Okay, the Ohana is a social determinant of health. So this is where the more nuanced layers of how social drivers really impact the Ohana unit. And depending on the social economic drivers at play for a community and Ohana, the Ohana itself can be a determinant or driver to health and wellness or to disease. So I just want to say, take the people in these photos in. As a family practice in a predominantly Native Hawaiian community, the bread and butter of the health issues we face with our patients clinically is diabetes. Meanwhile, what we see socially as a driver is the prevalence of multi-generational dwelling. So both of these health factors existed long before COVID and have since become exacerbated by COVID. So how does this work? I will give you a real life example of a patient deeply engaged in our diabetes management program a few years ago. A program, by the way, that was a 12-month commitment, mind you. Fully integrative care team involvement from PCP to behavioral health, chefs, dietitians, and on-site, as well as off-site health coaches. Let's call our patient Tutu Mary, and she's in her mid-60s. So Tutu Mary is engaged in every aspect of the program, and she's reaping the benefits. Her A1C is lowest that it's ever been, and she just feels good. Her esteem is up. She's doing good things for herself, right? She's making deposits into her bank account in terms of physical wellness. 5 months into the program, nearly halfway point, she stops showing up to these weekly groups and dinners. Our health coach immediately intervenes using MI training that we rigorously promote with all lines of staff. And she starts to discover, first that Tutu Mary wants to stay in the program, but she doesn't have the time, all of a sudden doesn't have the energy to do it. And so, we're asking what's changed, and we start probing. And what we learn through this process is that Tutu Mary's adult daughter, whom we'll call Alice in honor of the United Way Alice report, she lives with Tutu Mary along with her 2 kids and husband. And Alice right now and her husband are going through a nasty divorce. And husband has recently moved out of the household, right? So disarray. Alice is a young working mother who's now free time at the end of her workday spent navigating the divorce process. She's turning to her mother, naturally so Tutu Mary, to care for the kids, not just during the day, but during the evening as well. So Tutu Mary tells our health coach, she acknowledges, I know I'm supposed to be focusing on me and my health at this stage in my life, but my grandkids and my daughter need me. I can't do it. So here's what happens next. Our health coach, she doesn't stop there, as easy as that would be. Instead, she reaches out and she offers a customized service plan. She offers being able to meet with Tutu Mary on an individual basis instead of doing the groups on her own schedule. She offers assistance with time management strategies. And then she offers navigational support to pull in family support services in the community to assist with things like respite, with parenting support. And then she offers support counseling, but not just to Tutu Mary, also to daughter Alice and husband, who could also benefit during this time, and assisting them through that whole process of getting them each connected to the service providers of their choice. Tutu Mary ends up staying in the program. She stays She makes it to the 8-month mark, not 5 months, but definitely a long haul. And she does this with the customized service plan, while daughter Alice and husband actually take us up on our offer and enlist themselves in for couples counseling. Not for reunification, but to ensure an amicable separation and to learn healthy stress coping strategies to navigate their divorce with less tension, less stress, less anger, so that as co-parents together, they can show up in a healthy way for navigating life after divorce. So that's one example. It really can vary from there. I really look to stories like this because they're really foundational, I think. They're stories that tend to, for us as providers, fall into that quadrant where it's important. Yeah, we recognize that, but it's not urgent, right? It's not an urgent thing that needs to be addressed. So oftentimes it gets put on the back burner. And what happens is that we tend to miss an opportunity that provides great long-term systemic change in the lives of those we serve. So looking ahead, Kealoha. Looking ahead, the story of Tutu Mary and her Ohana points to the unmet need for and greater investment in policies and programs that provide what I've listed here. So our people do not live in individualized vacuums, although the health sector is built that way and we tend to operate that way. Our Ohana units are not. They're multi-layered individuals with multi-level complexities as families that are oftentimes multi-dwelling together. This story also, for me, speaks to the breadth and scope of change that can be undertaken when intersectional partnerships and collaboration take place. So what do we need to do more of in light of this, and who can help deliver that? In sake of time, I will be happy to share more information on some of the partnerships and other examples that we've done in our community to help prioritize that type of intersectional partnerships. But for now, I will close with this statement that if we work together across multiple sectors as a standard way of doing business in healthcare, we have the real capacity to frame early life exposures on future health, and that health can be transmitted across generations. So again, with that, big mahalo to all of you for choosing to be here with us this afternoon for this discussion. And a thank you to my fellow panelists and my team here on Molokai who make it all happen.
Thanks so much, Helen. Thanks for highlighting so many of the great programs that were born in the community and continue to be run by the community. And we hope to see those continue to flourish and thrive after the pandemic as well. I'm going to reference a couple of the polls that you folks were participating in while we were talking. And there's two things that jump out to me. About half of our audience here believes that the organizations that they're a part of have specific programs and initiatives that address SDOH, but also about another half believe that the health system is not necessarily doing enough to take SDOH seriously. So I think these are really good anecdotes and data points for us as we launch into the conversation. We have about 7 minutes left, so we're gonna continue to go through SDOH really quickly. But there are some questions that came up from the audience, and so I'll start with this one because I think that this is a great question, and it's really important to the audience and stakeholders who are here at State of Reform 2022 today. And it's, how do we encourage more social sector partners, the business community, and government to take decisive action on the upstream factors? That's us going back to the discussion today on housing, income, food security, and how do we get the message outside of our health care bubble and those that we might work with insularly every day. I think this is a great set of questions, and I'll go ahead and open it up to the group.
Well, I would like to take a crack at that. One thing is, I am not so sure that our healthcare industry itself is advocating as fully as it might on some of the important social determinant issues that we see in the community. So we all understand how important it is, but I would like to see every health plan, every hospital system, every medical group be actively engaged in advocating for housing, an increase in minimum wage, and other kinds of issues, the availability of food, all of the things that we were talking about here, and take that on as part of their mission and not pretend like that is somebody else's concern, because we do understand in this industry how important it is. We need to put our beliefs into action when it comes to advocacy.
Thank you so much, Beth. Accountability, I think, goes right along with just us having simple awareness and moving beyond. That awareness now seems to be top of mind for a lot of us. There's another great question in here, and I might just refer this one to Francoise. Since we know Quest beneficiaries tend to have more SDOH needs and have those gaps in the social risks that you mentioned, what do you feel like are some of the important strategies that we should be considering when we're specifically focused on Medicaid and Quest integration members? Just real quick, Francoise, if you can unmute, thanks.
The statement of the year, right? You're on mute. The one thing I'll say is we need to acknowledge that this is a really overwhelming area for multiple industries. And so I think in the healthcare industry, we've been dealing with it for a longer time. And so we're constantly challenged to get better. We are constantly faced with the fact that the outcomes that we want don't happen unless we really dig in and try to understand our populations better. And so for our Medicaid and Medicare population, I think health plans and other healthcare organizations, I'm seeing a growing shift in the understanding that this is really a barrier to us helping people to maneuver benefits. It's really a barrier to people effectively utilizing those benefits. And so I am encouraged by the change that I see there. But one of the things that we'll have to continue to do very well, I think, is population health. I think in our industry, we are accustomed to carving out high-risk patients and coming up with strategies for those patients. What I'm seeing more and more, and I'm encouraged by, is looking at the healthy population and making sure that they stay healthy. And especially in light of the pandemic, we have folks that were doing okay. And what we discovered, mainly because we took the incredible leap of finding innovative ways to communicate with people, is that there are folks who really were just barely hanging on. And so those people that we viewed as low to medium risk were really in danger of becoming our high risk patients. And I think we need to make sure we're focused on strategies for all of the population, not just our high risk patients.
Thanks so much, Francoise. In our rapid fire 30 seconds, Helen, I'm going to come back to you before we close out. This question I think is really important for CHC is, are you folks seeing progress being made on collecting uniform SDOH data and then being able to track that with your members? And sorry, you're muted too, Helen.
Uniform data collection. That's actually a project that we're working on, that we're just embarking on now. And it is in partnership with a number of other community health centers on Oahu as well as on the Big Island. So we have some of the tools. We have the early tools to start looking at a high level of our social service kind of activities and care coordination activities currently, but we are in the process of actually uploading or building out a new system for social determinants of health specifically. And that is it's going to be artificial intelligence based. So, which is exciting because I think the most profound feature that platform is going to provide us is a deviation away from all this coding activity, right? That's really cumbersome for all of our staff. And it's going to be able to go through and scrub our provider notes to pull anything that's addressing any of the topics that we just talked about that would qualify as a social determinant of health. And it's going to query and it's going to collate that data for us to be able to get really early insights on and strategize, right, with certain high-risk cohorts and take a look at what are the social drivers going on for those individuals. And then the last piece of that process is going to be looking at the cost involved and really getting into the details of predictive analytics to see, if this person is left on this track without any interventions made now, the trajectory and the cost trajectory that is going to cost all of us who are part of that person's life and has a chance now to make a change. So the short answer is no, not currently. We're having to do a lot of that manually. And then the long-term answer is we're currently in the process of getting a uniform system in place.
Thanks so much, Helen. Ending on AI and predictive analytics is such a forward look at the future. I'm excited. Thank you so much, Francoise, Beth, Helen, Aloha Care, the Hawaii Budget and Policy Center, and Molokai Community Health Center. Thank you, State of Reform. Have a great rest of your conference, everyone. We could have kept going for much longer, but we know that there's several other great and important panels coming up this afternoon. Feel free to reach out at any time. Aloha. We're all here. Aloha.
Thank you. Aloha.